Now the last speaker of this session, standing in between you and lunch, is Arvind Chopra. Arvind Chopra, Chandrasekhar has given a 2-page, very brief introduction to Arvind Chopra here. It's very abridged. That's what brief I said. Abridged this thing. Well, I'll tell you. Arvind is one of the, for the uninitiated people, one of the senior most rheumatologist, academic, teacher, prolific scientific investigator and an institution builder. Currently he is the director of Center for Rheumatic Diseases in Pune. He is the chairman of Bone and Joint Decade India National Action Network. He has also mentored a generation of rheumatologists. He runs a fellowship program equivalent to or better than DNB, and several rheumatologists have been trained and practicing in this country as well as abroad. He is also a visiting faculty to the University of Iran, and he has trained 7 PhD students, including from outside the country. More than anything else, he is the first Indian to be the guest editor of the Journal of Rheumatology, and he has been an invited main speaker at the EULAR and ACR Congress recently held about 3 weeks back, where he delivered a phenomenal talk on chikungunya arthritis to the American audience as well as the others who were there, to a standing ovation. They extended the session from 45 minutes to 1.5 hours. This is the first time it's happened in the history of American College of Rheumatology. And he is the father of the epidemiological rheumatology in India. He is the first person to take rheumatology to rural India. I don't know many people know the name Big One. It's a village in Pune. But if you go into the WHO website, they know about Big One. He started this COPCA study, community-oriented prevention of rheumatic diseases, a phenomenal study. WHO has accepted Arvind's study as a role model to every developing country, and innumerable number of publications. And first and foremost is, I must tell you, he is also an authority on biosimilars and biologics. Because Dharmanand spoke about methotrexate, Shankar and hydroxychloroquine, sulfasalazine and leflunomide. I think when all of them fail, can we look at Arvind Chopra for biosimilars and biologics? Probably he is one of the foremost authorities on biosimilars today. He was the convener of the first international working group on biosimilars, which group was aborted sometime couple of years back, where I and Shankar had the misfortune to be the members also. But he has done a lot of work. Most of the clinical research activities on biosimilars is done by Arvind Chopra. There are some other medicines in the pipeline, and he has a lot of hopes for us. And he is a very compassionate, caring human being. His patients love him. His staff love him. I know his center. And as I said, he is an institution builder. He built an institution called Bone and Joint Decade India, which did a remarkable work in this country. And probably other people noticed it. Only thing is, the Indian Rheumatologist didn't notice him for a very long time. Arvind, it's all yours.
Thank you very much for this very generous introduction. So you can blame him also if the lunch gets delayed. Chandrasekhar actually has posed a very provocative question to me. And I have been in a sort of a dilemma. Should I send you back home with your optimism in DMARDs crushed? Or should I send you back home with optimism in DMARDs restored? I think that is a very critical question. And so let me unfold the story. As we are running, I wouldn't say short of time, but I think we all are feeling hungry. So friends, and please refer to the talk that is published in the souvenir, and I'm not going to touch that at all now because it's already there. And I think that's a little bit advanced stuff which perhaps is okay for rheumatology fellows and registrars. So I will be trying to get quick messages out of this particular question, that when DMARDs fail, is biologic the next choice? But my question to you all is, do DMARDs fail? That is a critical question. And we hope and pray that they don't fail in our socioeconomic setting. Because there's a very heavy price to pay when DMARDs fail. Please remember, you have been told in the morning that rheumatoid arthritis is a lifelong disease. And we don't tell that to the patients, which I think is very important. Go tell that to the patients. Go tell them that this is a lifelong disease, but your suffering is not lifelong. And we are going to, or I am going to, control your disease and restore all the quality of life that you want. And your optimism, along with the optimism of DMARDs, will carry the patient through. So there are many issues, and I've quickly summed up here. And actually, some of us could be talking for 1 hour only on this slide. Out of literature, out of experience, these are important issues. So before you say that the DMARDs have failed, I think there's something like a checklist. And you'll be surprised that so many things have been neglected, ignored actually, and the DMARDs may not have failed. So my friends have said a lot of things which are in favor of the fact that DMARDs don't fail easily, and I'm going to perhaps not repeat some of those things have been said. Well, it's important that in today's time, when we have fields of molecular medicine, pharmacogenomics, we talk about receptors, we should also recognize that though small, but there's an important role that there may be an inherent or a primary resistance to some of these drugs that are used for chronic disorders. And some of the explanation for that resistance is in that article that Chandrasekhar has very kindly published in the souvenir. So that be it. Several control studies, observation studies, so many meta-analyses, they all tell us that there is a variability in the response to DMARDs. And this is true for many medicines. But thank God, no two people are alike. It's fundamental. So very often we are caught off guard. When we expect things to go right, very often they don't go right. So remember that there's a certain amount of variability in the biology of everyone for reasons that are largely unknown and some unknown. So remember the variability is there. And let me quickly sort of take it off my collar that any DMARD, even any NSAID, any analyst, they all have something similar that roughly they'll only work in about 60 to 70% of patients. And it's a matter of trial and error as to what you start with. So we also should never forget that this is the art of practice of medicine, not so much of science. And though based on knowledge and data and literature, we all acquire insights as to what we should start with. The only thing it doesn't come into this 70% is steroids. And that's what perhaps we'll again refer to later on. So it's true that methotrexate is gold, as Dharmanand said. Oh, he said gold standard. He didn't say gold, otherwise he would be so rich by now. I'm sure you are. So it is the gold standard. It is the pivotal drug. It's the mainstay therapy. Thank God there's methotrexate, otherwise you and me would be out of business. So that's methotrexate. You've got to remember that. Without methotrexate, we are at sea. I still remember several years back, Mahendranath gave such a very fiery talk. It was in one of the Iracons here only. Hit early, hit hard, keep on hitting with methotrexate. But that's true. And years later, we're only getting wiser and wiser with methotrexate. So I think we cannot give up methotrexate. And we have to give up methotrexate for the right reasons. I'm just repeating what Dharmanand said. Don't give up methotrexate for small issues, petty issues, small reasons. You know, doctor, मेरा पेट फूकता है, थोड़ा gas आता है, lose motion आता है. Oh, there's hundreds ways we can tackle those problems. But there are not 100 ways you can tackle rheumatoid arthritis. These are very, very important things to remember. So, one of the most difficult questions for me to answer this afternoon is the most pivotal question of my talk. How do you describe DMARD failure? And pardon me, I'm going to confine myself to methotrexate for the next 10-15 minutes. So, I'm going to talk about rheumatoid arthritis. Please accept that, please allow me that so that we can finish off at least one particular. I'm not going to talk about anything else. How do you describe? And this question is relevant perhaps at every level, whether internist is looking at the patient or as unfortunately we are a very small breed of rheumatologists, less than 300 dedicated rheumatologists. Sir, how many are the latest? Mahendra keeps a track of this. 350?
No, it has crossed 480, actually 1,200 are the members.
I don't believe that. Anyway, so even if the 1,000 rheumatologists lost somewhere in this 1.2 billion population country, it's a drop in the ocean. So who's going to treat rheumatoid arthritis? Everyone is important, right? From general practitioner, internist, orthopedic surgeons, we need to keep them in the fold. So I raise this question because they need to understand also what is an inadequate response to a DMARD or a methotrexate, we said. For a clinician, it always starts the way I learned years ago. My esteemed teacher is here today and I'm so happy to see him, Brigadier Kasturi sir, thank you very much. I feel very humbled. My very first paper came with him on connective disorders, 25 years data in an army hospital. So early morning stiffness. It was almost like a chronometer, more than 30 minutes. Every time the patient comes, that used to be the measure of disease activity control. And things got added to it. As rheumatologists, we know everything is important, the joint counts, the quality of life, the functionality of health assessment questionnaire, ESR, CRP, radiograph, everything is important out there, and the composite indices. And many of us may not have the privilege to do a composite index all the time. But believe me, that is not all that important. What is most important is what every speaker has said since morning, have a target. You pick up one good target. Your target could be that I don't want any painful swollen joints. Don't worry about the mathematics and the computational indices like DAS. Of course, they're very easy these days. It's all available on the internet, hardly takes. But I'm saying it's not important. Important is the target. You could choose anything target, but it should be a meaningful target. But let me phrase this particular slide by saying that most of us rheumatologists would perhaps say that if we exceed a dose of 15 milligram per methotrexate per week and go up to 20 and 25, and during this endeavor, we are trying to control rheumatoid arthritis the way it was said in the morning, and the patient has not shown side effects and not getting into control, at some point in time we'll say this is an adequate response, whether you call it failed response, whether you call it poor response. So most of us in clinical drug trials as well, it's a dose which is taken very often as inadequate response. We have crossed 15 milligram, we have crossed 20 milligram, and yet the patient is not adequately under control, whether DAS20 is more than 2.4, or the ACR 50, 70, 90 response is not there, or you just say as a clinician that look, morning stiffness, plenty of pain, plenty of swelling, the ESR, CRP is persistent, that's it. So it's a very clinical decision making which goes in. To my mind, this is a very basic definition of a DMARD. I keep going between DMARDs, methotrexate. But the thing which I want to tell you today is that as rheumatologists, we have something like, this is from Kelly's new textbook, but I think the numbers are more. If there are 10 synthetic DMARDs and 9 biologics approved by the US FDA, and no 2 biologics can be combined, that's not advocated, and we know there are a lot of problems. Now, if you put all this into permutation combinations, then my friend James Odell, he writes that there are 2,569 possible combinations. Can DMARDs fail? We have to find out that the magic combination. And of course, there's science behind it. We don't use everything. So let me quickly walk through the literature now. I think we owe it to James Odell, a brilliant American rheumatologist, started with the RAIN network about 20 years back. And in late 1990s, he said the triple chemotherapy is excellent. It works in all difficult situations. But even 20 years later, because it's a triple chemotherapy, 3 drugs, it's easy to talk on the stage and say that we add efficacy, we don't add toxicity. But in the mindset of many clinicians and even rheumatologists, it doesn't come very easy that should I give all the 3 drugs, how long will I give it? And it's not only 3 drugs that the patient takes. Remember that the prescription of rheumatoid runs into a page or pages. So there are some issues based on which this chemotherapy, though scientifically very robust, a lot of data is there, still it has taken us almost 15-20 years to place it, to position it in the ACR guidelines, where is triple chemotherapy? Are you going to start on day 1 of an early rheumatoid arthritis with bad prognostic features? And today, we do not know clearly what are good prognostic features and what are bad prognostic features. We have changed that particular statement all the time. All the guidelines start with identify in your patient with rheumatoid arthritis what are the bad prognostic, what is good prognostic. For example, the gender, the persistence of synovitis, not responding to NSAIDs, not responding to steroids, quick changes of the drugs, persistent ESR, persistent CRP, high joint count for swelling, high HAC, high DAS, all those things are there. But do we know where the mathematical cutoff? No, we don't. We create indices, but it's very difficult. Because as I said, we get surprised. Sometimes we feel this patient is going to not respond, the patient responds like that to something that we do, which I'm going to talk in a little while. So we go by the science, but basically I think what we do a lot is you need close monitoring. That's important. Education of the patient and monitor the patient. That you look very bad, but stick to me. Give me some time. I'm going to start this. Explain to the patient, like very nicely ChanRe said about education. It's very important to tell the patient upfront what to expect. So this was one of the very first publications on chemotherapy, combination of hydroxychloroquine, methotrexate and sulfasalazine. And Odell didn't stop in 1996. And I think he's one of the very few physician scientists who persisted with his sort of his strategy. And today he has a maximum number of work in this field, improving. So let me quickly now, as you can read out here, that this combination works very nice. There's another 2 years randomized double-blind parallel study. But these are moderately advanced rheumatoid arthritis patients, remember that. And they had a poor response with 17.5 milligram per week patient was chosen. Superior efficacy in triple versus all combinations. All combinations were okay, hydroxychloroquine, sulfasalazine plus methotrexate, but the triple did the best. But this was not statistically significant. And then I think this is a publication which are postgraduates here, rheumatologists, you must not only go through this publication, but you must actually discuss it with your mentors. This is a publication, I think, which is most meaningful this morning to what Chandrasekhar has said, a relook at DMARDs and methotrexate. And I think this has been an eye-opener. Same author, James Odell, and his multi-centric studies, which was published in Medicine. And I've just picked up some quick things, messages for this. Is a 48-week trial, active rheumatoid, despite methotrexate. And in this particular study, the mean dose of methotrexate which the patients had inadequate response was something like 19.5 milligram. But that is a lot of methotrexate. For 3 to 4 months on methotrexate, 19.5 means that these patients really had bad rheumatoid. And you can see the DAS was very high. And in this particular study, this was designed as a non-inferiority trial. There were 2 limbs. One particular limb got triple, and one limb got methotrexate plus etanercept, because we are talking about biologics. So actually a biologic has been given. First major head-to-head comparison, similar to another sterilization, infliximab was also compared, which many of us know about it, in BEST and all this. But this study was upfront between etanercept and methotrexate versus this. And what do you find? And it was very clinically oriented, very pragmatic study. The clinicians, we could change the doses, etc. But 40% patients were on methotrexate. Both the groups were well balanced, as you can quickly see. Females dominant, high rheumatoid factor, DAS 28, 5.8. In the morning it was mentioned that 5.8 is a very high disease activity. And you can see some of the things quickly, but obviously you need to go through the study to enjoy it. And about 50% patients were on steroids, both arms, less than 10 milligram. At the end of 1 year, the first analysis was 24 weeks and 48 weeks. No differences. Patients on triple DMARD with or without steroids were no different from patients on methotrexate plus etanercept with or without steroids. About 55% patients responded at the end of 1 year. 55% almost went into remission. That was the primary endpoint. It told us so clearly about the socioeconomics. So is there any sense in giving biologic on day 1? Chemotherapy is good enough. This was one of the conclusions of Odell and his group. And in adverse events, there were no difference with these two, though we are using biologic. No significant differences except that one patient died of pneumonia in the methotrexate plus etanercept limb. And there are 5-6 more serious infections. Statistically not significant, but that was important that there was a death because of severe infection in that group. Conclusion, triple therapy was non-inferior to etanercept plus methotrexate. Etanercept, just want to share, is an anti-tumor necrosis factor agent given subcutaneous weekly despite methotrexate. Another sort of a landmark study was what's called TEAR, which many of us rheumatologists have enjoyed reading about it. This again a 2 years randomized double-blind placebo-controlled, a little complex design, but 4 limbs this time. One triple plus ETA, 2 limb methotrexate mono. But at the end of 24 weeks, if these patients do not show response, they could be upgraded, they could be stepped up. So people who were only on methotrexate after 24 weeks, that was almost 6 months, some of them went up to triple and some of them went on to adding etanercept. Like previous trial, but remember the 4 limbs now, the difference. And in this situation, these are early RA. In fact, the mean disease duration was only 3.6 months. As early as that, very aggressive RA. And let us see what happened. And the target was, you got to get the DAS28 into a remission or a low disease activity. 755 patients, enough. Of course, they fell short of the target, but still this study was had adequate power. Past methotrexate use only 25% less. Prednisolone use 45%. 68% patients completed 2 years. Now please remember, you have been told in the morning about treat to target. Now both the trials, the clinicians have looked at the patient's DAS. If you don't meet the target, you increase the drug. If you meet the target, you continue that particular level of dosing. So these are treat to target trials. Despite everything, 68% patients, irrespective of whichever limbs they belong to, complete 2 years. 72% in the step-up arm stepped up therapy at 24 weeks. I mean, 24 weeks, 72% patients needed escalation. What does that mean? That means about 30%, I'm giving you some round figures, 27% to be precise. That means 27% patients on methotrexate alone achieved the target at 24 weeks. Easy? Clear? Alone, nothing was there. And you look at the DAS28 response at 24 weeks. The patients who got etanercept or triple were only 41%, which is very meaningful. Not that it's not meaningful. These are strong responses. And this is the most important message which emerged. All the 4 limbs at the end of 2 years were the same. End of 2 years. Except for radiographic. I'm going to talk about a little bit about that. When it came to ACR 20, 50, 70, which are American Rheumatology Improvement Responses, composite indices, I don't have time to explain that, but it's like DAS, but it's more clinical. All patients must show, for example, 20% improvement in joint counts for pain, tenderness and swelling, and 3 of the 5. And you also have to have, out of the 5, pain VAS must go down, the patient global assessment must be better, HAT must go down, and you must have one of the acute phase reactants improving. So this is how you derive that ACR response. The only place where etanercept was better was in ACR 70, but that's a very small response. Okay, conclusions. Remember 4 limbs. 1 limb, day 1, triple. 1 limb, day 1, methotrexate plus etanercept. 1 limb, only methotrexate, which 6 months later added on, went into a triple. 4th limb, start with methotrexate only and later on added on etanercept. 4 limbs going forward, no difference. You can read on the slide. So what did we conclude, which is important to you and me, is that perhaps on day 1, why expose our patients to triple therapy? That was one of the things which came out for the first time. And again, Odell is part of this group also. So let me go a little ahead to explain to you now. Okay. The TEAR data was again analyzed, and again that same big group with Odell and all his friends all over the world. I think this is what sums up, which adds to that 30% of patients with bad rheumatoid on day 1 perhaps will do good only with methotrexate monotherapy being escalated with or without bridging use of steroids. And maybe 6 months later, these patients, some of them are not doing well, may require a triple drug response, and they will also go ahead and do well after 2 years. And the monitoring, what we learned from this is that monitoring should be done within 3 months, but within 3 to 6 months you should change your therapy. But I'm not talking biologics so far. I'm still restoring your confidence in the fact that DMARDs can do what you want them to do. But methotrexate is pivotal and a triple is there. The summary of this particular slide is that yes, won't go into details. There is very elegant work to suggest that please change to subcutaneous. If the oral is not working, patient is not tolerating, there's a method how to change to subcutaneous, try parenteral methotrexate. And there are lot of data say that that will possibly give you the effect. This is one of my most favorite papers that I read during this preparation for this talk. Now there's an elegant paper published from Smolen's group which tells us that patients who have failed methotrexate and the clinician took under discussion, the clinician gave some other combination, leflunomide or anything, but not methotrexate. When these patients who had failed methotrexate were given other DMARDs, still did not respond, you give them back methotrexate under the so-called treat to tractate supervised, and almost half of them showed response. So there was no lack of response or loss of response. It only tells us that perhaps we were not very scientific to start with in treating these patients. It should restore us that maybe at times we should be looking at methotrexate again and again, and this was a paper published there. Corticosteroids, what's wrong with them? We all use corticosteroids, but we are scared to talk about them. At least at times, Brigadier Kasturi sir, you remember that steroid was a dirty word. When I was doing my MD, it was a dirty word. Nobody wanted to talk about steroids in rheumatoid arthritis. It was as if, it's something which is, anti kind of establishment. We cannot do without steroids. Let me put my philosophy across. The man who discovered steroids deserves many more Nobel Prizes. We continue to discover newer mechanisms of actions as to how steroids work. We have already gone into intercalating DNAs and right into the molecule as to where steroids work. The only problem is how to tame this lion. If you know how to tame steroids, that is the crux of the matter. And that's another talk some other day, that yes, we all should be able to use steroids intelligently in patient rheumatoid arthritis. I think this is good enough. There's a lot of excellent data, read about it. And this trial, and a lot of good data from the trials which tells us that yes, steroids can be used very intelligently to augment the effect of triple and what I spoke. It's the Cobra trial which taught us that you can induce remission in rheumatoids with a high dose steroids, rapidly tapered within about 28 weeks or so, and continue maintain your response with other drugs. That was the Cobra trial. But a very recent trial, which I think some of my colleagues must have read, is this year. And these people from Belgium and Europe worked out another regime, a clinical drug trial, DMARDs naive RA patients, and 3 types of Cobra regimes now. The classic, the slim, we won't know details. The fact is, these people are looking at the so-called bridging therapy with steroids. And bridging therapy also includes parenteral therapy, which I am very fond of. Most of the times in my patients, when they come to me with bad rheumatoid to start with, I invariably give them 80 milligram methylprednisolone weekly for 6 weeks. But some of my colleagues will only give 120 milligram single, which was part of this particular study. They call bridging therapy or maybe some intra-articular. And there you are. And then in this particular study they said, nobody will fail. Whether you use methotrexate or you use triple, add bridging steroids, you got what you want and you can maintain it. But then Chandrasekhar has called me for a reason. He doesn't want me to only sing songs on methotrexate and triple therapy. Of course there's a place for biologic agents. It's one of the best things to happen in the world. It's a revolution. It is a revolution. At the turn of the century, one of the biggest discoveries, biological agents. They have cut across so many specialties, especially oncology and rheumatology, I think, are at the forefront. These are missiles. And there's enough data to tell us that in situations where the DMARDs have failed, and I'm putting a question mark, I'll come back to again, where you really think the DMARDs